Good evening, good morning, and good afternoon. Good morning to all our friends and colleagues from western part of the world. Good evening from the eastern part, and good afternoon to all you are there who are into the European countries. So we are back here again with the global summit, and as you know that we have been bringing in the top 100 guys all around the world. And here with me today is uh, we are back here with my brother from Pakistan. We have been knowing each other since long, and presenting you here, Dr. Irfan Qureshi. Uh, 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 it's an immense pleasure for me to be here and host him on Global Summit. And today I'm all alone here to as a board member of Global Summit, and I'm the host, and I'm the one who is introducing. So everything is being done by me, and we are going to listen to see few of his fantastic cases. Um, I would like to talk about something about him. Uh, he's based in Karachi, and let me tell you one thing that I got this chance to visit his clinic in 2000, um, probably it was 16,
Yeah.
2000, 2016, in one of the elitist of the places in Karachi, which is known as what do you call that place,
Clif-
Irfan?
Clifton.
Clifton.
Yeah.
Clifton. Clifton is supposed to be the best place in Pakistan, Karachi. And he has a wonderful clinic there. Amazing clinic. I was mesmerized and I was like, oh my God, it's OMG. Uh, so he's based in Karachi, and Dr. Irfan Qureshi is the first and the only Pakistan based clinician to earn diplomat in implant dentistry from the prestigious Royal College of Surgeons, Edinburgh, where he was recently appointed on as an examiner for the diplomat implant dentistry exams. So that's a great honor for my brother and from Pakistan. And let me tell you another thing that we have a invisible line between our two countries, but our hearts are, they beat together. He's a wonderful person, above all, everything, and a wonderful host. I still remember the evening there at the seaside of Karachi, and Karachi is just like Mumbai. You know, we have Mumbai in India, and Irfan has Karachi in Pakistan. It's almost similar. He has earned a master's degree in prosthodontics from King's College London. Dr. Qureshi is a diplomat of the International Congress of Oral Implantologists (ICOI) and serves as the ICOI ambassador to Pakistan, which is again a big honor because the ICOI ambassador from India is Lanka Mahesh, Dr. Lanka Mahesh. And we all three are very close brothers, and serves as the ICOI ambassador, as I told you. And Dr. Qureshi is also a fellow of WAPS. So this is again a big link between us. WAPS. WAPS is the organization which has been founded out by Professor Dong Seok Son in Korea, Daegu, and he's an amazing person. World Academy of Ultrasonic Piezoelectrical Bone Surgery, and he's the fellow of IDIA at the at 2011 ICOI World Congress. Dr. Irfan placed third at the Young Oral Implantologist competition. In 2015, he won third prize for the best clinical case contest at the Global Dental Implant Academy. So, since we are little delayed because of some technical problem, I would not like to take much of your time and Irfan's time, and I'm presenting you, handing it over to Dr. Irfan Qureshi. Welcome. Assalamu alaikum.
Thank you, Sandeep, for the wonderful introduction. And so you're taking over the presentation? Okay, all right, perfect. So I'm just going to switch that to play. Okay, so in case you stop hearing me or you stop seeing me, if there's a glitch, you will let me know, right, Sandeep? Can you hear me?
We can hear you, and
Okay.
we'll send you in. Anshu, Anshu is there, and he will take care of
Okay.
everything. Nothing to worry. You can start up with your
Okay.
presentation.
All right. Perfect. So, thank you very much for the wonderful introduction, Sandeep. Again, Assalamu alaikum, everyone. Sat Sri Akal, Namaste. Good morning, good evening, good afternoon, wherever you are in the world, the viewers and the audience. Um, so I titled the presentation as what you see on screen uh, for a reason, especially given what the world is facing these days. And I thought, Sandeep, I'm the only speaker from Pakistan in the entire summit. Is that correct? I think I'm not wrong when I say that. So I thought, let me show you something about everything, a little bit of everything that we do. Okay, so I thought I'll show you a little bit about my country and just set the record straight. Some misperceptions about Pakistan. Uh, I just want to show the viewers some of the beautiful landscapes of Pakistan, the beautiful people in Pakistan, who, contrary to what many might believe, are progressive, they are passionate, they love their art, their fashion, they contribute towards all parts of society, and some of them are beautiful people. These are some beautiful faces from Pakistan. A really interesting fact that I want to share with the audience, along with the reference, is that Pakistani men are ranked the third sexiest in the world. Okay, so this is the father of Pakistan, and as you can see, he's even for his time, he's a very aristocratic, progressive looking gentleman. Nothing backward about him. Now, I'm the president of the Federation of Implant Dentistry Pakistan, which was founded in 2011, and we've hosted a couple of very high-profile, high-quality events. And this is in 2012, and friends from all over the world, they joined in to lecture for us, and we had a lot of fun while doing that. That's Dr. Lerner from Germany, Jin Kim from the US, Marwan Qasim, our brother from Palestine. Aldo Vicari has been to Pakistan to lecture for us. The late Aldo Vicari, maxillofacial surgeon who passed away, I would say before his time. He was a wonderful human being, and we had a lot of fun. Aldo Vicari made sure that Jin Kim passed out, partying hard. If Jin Kim watches this, I'm sorry for sharing this with the world, Jin. And this was one day before the main podium lectures, and that's quite a story for another time, perhaps. Majid Abu Arqub, our brother from Jordan, who's supported us through several events, and this is Majid and I lecturing together in Bangkok. 2014, we held another really big event, a massive event, which was very well received, and it was a very high-profile lineup of speakers. So as Sandeep has already told you about myself, on paper, I'm a prosthodontist. So far, the first one from Royal College of Surgeons with a diploma from the Royal College of Surgeons in Pakistan in implant dentistry. I'm the ICOI's ambassador in Pakistan. This is our practice in Karachi. Just to give you a quick view of some of my colleagues, the practice is it's a labor of love, really, and we work very hard to make it a pleasurable experience for all patients, visitors, and it's been an honor to work with the colleagues here. So, just some of the pictures from the practice. This is a little slow to move. Okay, just some visuals. This is where we work. That's our colleagues a few years ago, 5 years ago, working hard on Christmas Day. I'm a big supporter of General Pervez Musharraf, who was president of the country for about 10 years, and which I consider the golden era in Pakistan. And I'm very proud to say that he was a very happy patient with us at the practice. We did a lot of work for him until he was in the country. So I would like to start the lecture itself with this thought that as professionals, God has given us the ability to change lives and to really have an impact on the lives of some of our patients. When a patient walks into your practice looking like this, and you transform them and enable them to smile and to eat, I mean it's a very gratifying feeling. So from here to here, and cases that finish well, it's a very gratifying feeling. This patient was falling apart. A lot of his teeth were literally falling apart, and we restored him, and he's able to have a very wholesome quality life. This patient could neither smile nor eat, and we were able to restore the patient with implants, and she's very happy. Another patient who flew in from Chicago to get his treatment done, he was severely handicapped, and then this is how he went back. He's still in touch with us, and it was again a pleasure to treat him. Another patient who flew down from the US, San Francisco, I believe, severely periodontally compromised teeth, and then we put her back together. Another patient, this guy was, we finished his work in progress. We finished his lower teeth a day before, or I believe the morning of his wedding, actually. He was getting married the same evening. This guy had his lower bridge, which was literally floating, and we managed to put him back together with fixed teeth. So another case, he can now smile and he can eat. Another patient whose life we transformed, I believe, and I will show more detail about this case later on in the lecture. This patient was severely mismanaged earlier by the previous dentist, and the upper bridge was completely compromised. All the teeth were broken with their cores, and we managed to restore this patient. So, we live in unpredictable times, and every country, every culture has several challenges which are sort of specific to that country and that culture. And I thought I would share with you the challenges we face in Pakistan and how we are able to overcome those challenges. So aesthetic challenges is what I would like to show you first, and how we deal with them. Here is a case which was done in 2010. A young male patient in his late 20s. The lower right premolar was non-restorable. And this guy's father was the Chief Justice of the Supreme Court of Pakistan at the time, one of the most powerful men, perhaps the most powerful man in the country. So it can be quite intimidating treating patients like these sometimes. So I performed an atraumatic extraction, and the buccal plate was preserved, drilling into the base of the socket to get primary stability. And this was a bone level implant. And if there's any Dentaurum people watching out there, I'd like to say you're welcome. Also, I'd like to say here there is no monetary motive or compensation involved in my lecture. Just several brands that I use. They had a very sexy looking surgical kit, which I found quite attractive. So the implant was placed. It was a 3.7 platform implant. And you can see the mesiodistal dimension was didn't allow me to choose a bigger implant, which is why here I would like to mention the mesiodistal consideration. Several books and literature record that the tooth-to-implant distance should be at least 1.5 to 2 millimeters. So that is why the platform of the implant was chosen, and there was quite a large jumping distance between the implant surface and the socket wall. And I'd like to share this interesting paper here, which says that as the buccal plate thickness approaches 2 millimeters, you can expect very little bone loss. So a particulate allograft was placed in the jumping distance here, and a periosteal release incision was done, and the barrier membrane was placed, and primary closure was achieved. Now, this was one of my exam cases for the Royal College Diploma exam, and I knew that I'd be questioned about the periosteal release incision. And when I set about searching the literature for periosteal release incision, I couldn't find much. So I found one paper, an editorial actually, in the JOI by Dr. Romanos, where Dr. Romanos described these basic guidelines for the periosteal release incision. So this is the implant once it had integrated, and this is a few days after the gingival former was placed. This is an implant level impression with the impression coping in place. A polyether impression material was used to do the implant level impression. Okay, and so let me just, I think this is slowing it down. This is a mill department which was transferred, and that's a PFM crown which was placed. And keeping in mind the Tarnow's rule for restoration contact point and the papilla fill-in, which Sandeep mentioned very nicely and in great detail in his lecture. So we kept in mind the Tarnow's rule too, and this is the crown on the day of placement. 6 weeks later, you see papilla filling in, and 2 years post-operative, you have papilla nicely maintained. I presented this case in 2011 at a World Congress for ICOI in Seoul, won a third prize for it. And this is an 8 years post-op picture, and that's the 8-year post-op panoramic X-ray. So the next challenge is narrow spaces. This patient was 25 years old when he came to me. He's a heavy smoker, party animal, very hard to control. And he had a congenitally missing lateral incisor, and canine had drifted into the space of the lateral incisor, leaving space distal between the canine and the first premolar. And the space we had available was about 6 millimeters, barely. We had quite a lot of bone height available, and the bone width, again, between the two roots was compromised because the roots were tilted. So again, the mesiodistal considerations, the tooth implant distance should be 1.5 millimeters, and if you leave 1.5 millimeters on each side, in this case, that gives us 3 millimeters that we are left with in a 6 millimeter saddle area. So the implant platform then logically should be not more than 3 millimeters. Yeah, so this 6 millimeters of space, implant platform should be no more than 3 millimeters, and preferably a tapered implant, because the mesiodistal space between the roots is even lesser than 6 millimeters. So the implant was chosen, and the next challenge now is to get the implant in the correct position. And the surgical guide was made. So you have to strive for perfection, okay? And every tool possible was used to make sure that the implant goes in the planned position. And this is the implant. And this is the immediate post-op placement of the implant, which has gone nearly to perfection. That's once the implant is integrated. And that's the finished crown. This picture that you see now is 8 weeks post-op. You see papilla filling in an area where there was never a tooth. And this is 6 years post-op. And in a patient who's a heavy smoker, the soft tissue seems to still be holding. Okay. The next case is again very interesting. This was a 43-year-old female referred to me by a colleague, non-smoker, non-diabetic, and she gave a history of never having a first molar tooth present. And on the X-ray, she seemed to have a bony lesion. This is the occlusal view. So I went ahead, that's the occlusal view for you again. So I went ahead, raised a flap, and I used one of our implant drills actually to access the area, remove the lesion, and you can't possibly think of placing an immediate implant here. Yeah, so the lesion was removed, sent for biopsy, the defect was cleaned up. So the plan was to place a graft material and come back in a few months and place an implant. Now, if you use a particulate graft, one challenge that we have faced over the years is graft migration, where a lot of the graft material is taken away by saliva and bleeding. And that's where I think sticky bone really changed the game, because certainly the graft migration challenge was nearly completely overcome. And PRP, growth factors, autologous fibrin glue, there's a lot of literature out there about it now and how it is of great value in implant dentistry. Professor Son has done a lot of work on this. So that's our the armamentarium we use. That's the Metafuge by Silfradent. So a fibrin block is harvested, which is right here in the video. And it's then pressed into a membrane. And the membrane has very high tensile strength. As you can see, it can even hold the stiff. And okay, so yeah. So we also harvested growth factors in the liquid phase. Okay. Autologous fibrin glue, which is mixed with particulate bone graft. Okay, right here. And as the AFG, the autologous fibrin glue, polymerizes, it gives us a nice putty consistency sticky bone, which can be placed inside the defect now. And it was overlaid with a CGF membrane and a collagen membrane and sutured up. So that's the immediate post-op X-ray. It turned out to be a compound odontome. 3 months later, when we come back, we have a big chunk of bone, and I was able to place reasonable sized implants. That's the pre-graft and the post-graft comparison. I was able to place a 5.2 millimeter platform implant with very good initial stability. That's the implant. Now, coming back again, after 3 months of the implant placement, as you can see, the tooth mesial to the implant was also root canal treated. How do I ensure that my implant is stable and integrated? Now, we've been using several things over the years, several techniques, radiographic interpretation, a percussion test, a very rudimentary way of assessing implant integration. It's actually being quoted in the literature as well, albeit a very old paper in 1985. But if your hearing is fine, you can actually make out that's a different sound. Yeah. There you go. However, the gold standard is still resonance frequency analysis, the ISQ value using an Austell device, and the ISQ value of 60 and 90, between 60 and 90 indicates optimal integration. So that's what we used, resonance frequency analysis, and we got an ISQ of 82 and 74 in the proximal and the buccal region for the implant. So that was a very encouraging value, and we went ahead and we restored the implant with peace of mind. And that's a 3-year post-op X-ray showing the implant. And so this case I presented in Turkey in 2016 at a poster contest, and it won third prize. So again, sticky bone, I would say, is of great value. Now, one point I'd like to make here is, let me just hide this. This is bothering me. Is how implants are misused, and they're literally prostituted across not just in our country, in most countries, I would say. So I'd like to quote this excerpt from Professor Bartlett's book on how restorations in this field of dentistry can be the finest service or the worst disservice that you can subject the patients to. So here is a case where these are Straumann implants, ITI implants, nothing wrong with the implant system, but the prosthesis and the planning is hideous. This case was when the patient came to me, this was done by a renowned oral surgeon in our city, and that's what it looks like. This patient had initially, before getting implants done, had come to me for a consult, and he didn't find me charming enough to go with his case with his implants at our practice. So he went somewhere else, and apparently a big name, a specialist, and for some reason they prepared the adjacent tooth also. And when the patient was not satisfied with the restorative phase, he came back to me, and at that point I couldn't really do anything. Another case, and I can speculate that the previous clinician was trying to place an implant simultaneously along with the bone graft in the sinus augmentation. So you have to be very careful when doing these cases. This patient came to our practice a few months ago, and he told us that the implant in the upper right sinus has been sleeping peacefully for the past several years. Watch closely in the patient's lower left molar. So this patient said she had a lower left molar extracted, and a bone graft was done at a high-end clinic in Boston. And she came to me to get an opinion for an implant placement, and I had to break the news to her that there was a root tip still left in there, so we had to work our way through her bone graft and remove the root tip, regraft the area, an implant was placed, and then restored. Have a look at this case. I mean, this is quite a nightmare, and the lower bridge was floating. Severe resorption around the implants which have failed, and the patient surprisingly had no nerve symptoms. So we removed and cleaned up the entire area, and sticky bone was grafted where the areas of high resorption were, and implants placed, and finally restored. Another case where the lower left bridge had failed, it was mobile, and when the patient came to me, the mesial implant was mobile, and I can see the ridge is very thin. And perhaps that's why a long span bridge was placed on implants which were narrow. And this brings us to the challenge of narrow ridges. So for this patient, we raised a flap and we performed a ridge split procedure using piezo surgery. And so the failed implant was removed. The area was cleaned up, and where the failed implant was removed, we grafted that area. And where the ridge split was done, we placed two bone level implants. Okay. So we closed this up. CGF membranes placed, and primary closure was done. Okay. And as you can see that the tooth mesial to the previously failed implant has a pathology also, so we plan to do a root canal for that tooth. So 4 months later, we come back to replace the implant which had failed. Okay. Yeah, so the two implants that you see on the distal end, where the ridge split was done, those were placed 4 months prior, and the new implant is the implant next to the tooth. So this gave me a chance to take an optimal value.
Get both of these, yeah.
The value was 65. That was very encouraging. Okay. All right. So the area was then re-augmented just for my peace of mind, and this is slow to move. Okay. All right. So yeah, so the area was re-augmented and sutured up. Now 3 implants are in place, and the tooth mesial has been root canal treated. And then finally, another 3 months later, the 3 new implants were restored. The old implant, I didn't know what system it was. We couldn't figure it out, so I left it there as a sleeping implant. Another case, a disclaimer here, the upper implants were not done by us. The lower right bridge had failed. It was mobile. So the bridge was removed. And so the ridge was really narrow, as you can see. So again, a ridge split was done. 3 implants were placed. And then there was bone augmentation done. Okay. CGF membranes, primary closure, and these are the 3 implants placed on the right side. The left side was restored as well. And then finally, the 3 implants on the right side that you see in the ridge split area, they were restored. They're integrated nicely and restored with zirconium crowns. So, and again, as I mentioned, changing lives. This is another very interesting case. This lady was in her mid-50s, and she's a big-time socialite in Karachi, which, by the way, is a city of 22 million. And she had this anterior bridge, the upper anterior bridge, which had been failing for a few years, and a lot of bone resorption. And she had consulted several clinicians earlier, and they had given her options such as onlay grafts and autogenous hip grafts. And if you tell, as a patient, it can be quite intimidating and petrifying actually to hear of rib graft or taking graft from the mandible as a donor site. So she was quite scared, obviously, and she went on just like that with a wobbly bridge in the mouth until one day the bridge fell off. And that's when she came to us in panic, looking like that, and not very happy. And obviously, she didn't want any invasive procedures done. So I decided to take my chances. So I opened up the area where the bridge had failed, curated out all the dead tissue, all the granulation tissue. And you can see the ridge is narrow. It's a V-shaped, deep vaulted palate, V-shaped anterior maxilla. So I made some bleeding points, and perhaps at the time I was overconfident even of Sticky Bone's ability to give results with GBR. But anyway, I did Sticky Bone graft using allografts, and these are CGF membranes. This is a primary closure. Okay, CGF membranes, primary closure, and you go home and you start praying. 4 months later, I come back. 4 implants were placed in the grafted site with good initial stability, and did some add-on grafts at this time also. So again, that's the closure, and you go home and you pray some more. So at the second stage surgery, when the patient comes back, the implants had integrated, and we used angled abutments. Now, one of the problems was this really large vertical defect that the patient had, and I couldn't possibly grow any bone there. So we decided to do the prosthesis in 2 different portions. So we made a buccal prosthesis, which would be cemented onto the abutments, and then the actual zirconium bridge would be cemented on the buccal prosthesis. That's what it looked like. So these are the abutments in place and the tissue looking nice also. So the buccal prosthesis was tried in for accuracy of fit onto the abutments, and once that was verified, check the labial fullness coming back with the buccal prosthesis. So the actual bridge was cemented on to the buccal prosthesis extraorally outside the mouth, and then the buccal prosthesis was cemented onto the abutments. So that's how her smile was restored. And she went from here to here. And how's that for a life-changing experience? So she went back really happy. She basically got her life back. Okay. That's the x-ray. This case has now been finished since about 2.5 years. So another very exciting development in our country was going digital. Now, I had been running after this for a couple of years, and about 2 years ago, when I started doing digital dentistry, there wasn't much going on in Pakistan. The labs only now have started digital workflow. And I looked at several intraoral scanners, and without taking any brand names, I have to tell you that some of them were quite very slow, not user-friendly, quite a nightmare to work with. Okay, so this case I had done a few implants for already and restored them. So the lower right implant, we went digital, and we thought we would make a customized CAD/CAM abutment for this case. Okay, these are the design stages for that. Okay, and the plan was to give a cemented zirconium crown. Okay. Right. That's the design stages. Okay. So let me just go back. Yeah. So that's the customized CAD CAM abutment. This was my very first case with this abutment, so I was quite excited at the time. And that's the abutment in the patient's mouth. Very different to conventional abutments. That's the abutment, and that's the crown. And this is the brand I used, two abutments based out of Anaheim, California. Very satisfied with their product. So there's several advantages to using custom CAD/CAM abutments. You can customize the finish line to the gingival margin. You can get a better emergence profile. You get greater surface area for cement retention, and you can avoid deep finish lines and cement trapping. So then, gaining more confidence, I went ahead and started doing more digital dentistry. Another case, upper left premolar, and we decided to do a CAD/CAM abutment for this patient. And I'm very happy with the speed of the 3 of I have the cordless version, which is very convenient to use. So the scanning speed for this is not fast. Okay. That's the scan body being scanned. And you can also do a bike registration on the software, which is very pleasing actually. So, bike registration being done. Okay, so that's how we do it. We email these scans to the lab in California, and then they courier the case to us. So until such time that this thing catches on in my country, this is how I'm doing it. Um, all for the love of the game. Okay. All right. So let's just skip these. So again, the plan was to do a CAD/CAM customized abutment with a zirconium crown. These are the design stages again. Okay, so 3D printed models with a screw mountable crown. This is the articulated models, which are articulated with tripoding. Um, so, and if you get this right, it's it's very convenient. You simply remove the abutment and crown assembly from the model, and you transfer it to the patient's mouth. Okay. And you torque it. Okay, and then the screw access hole can be blocked out with composite, and that's the finished case. So that's the X-ray. Another case, where the upper left hybrid bridge had failed. The abutment tooth had become loose and it had a failed restoration also. So we extracted the abutment tooth and an implant was placed in the pontic area and the saddle area, and another implant was placed as an immediate in the extraction socket. These are the two implants. And now we get the case at a few days after the integration and the gingival former has been placed. So that's the soft tissue. Scans are done, and two screw-mountable crowns are fabricated and installed. And again, the occlusal access holes are blocked out with composites. So that's the finished case. Another case where the upper right bridge had failed. Now this lady actually had a gag reflex. And you can see the dentistry done in her mouth also is in great dentistry. So she's petrified of giving conventional impressions. So we removed the upper right posterior teeth. Two implants were placed in the saddle area. And these are the okay. The canine tooth, which was the abutment for the previous bridge, was crowned, the single crown, and two implants also restored again with screw-mountable crowns. And I like how these 3D models are articulated. It's very convenient. No more struggling with plaster of Paris and dental stones. Anyway, so these screw-mountable crowns are simply then removed from the model and torqued into the implant. Okay. And that's the finished case. So sometimes, and that's the that's the finished case. So sometimes we are able to do troubleshooting also with these customized abutments. This is a case, and the patient suffered for several years. This implant was placed very deep, as you can see, and this system does not have abutments with higher gingival heights. So the previous crown was oddly shaped, and the patient had a lot of problems with food impaction, perio problems, and tissue reaction. So we again fabricated a custom abutment for this patient. Now this custom abutment corrects the vertical deficiency problem, gives us a supragingival finish line, and we are able to give a reasonably contoured crown, and the patient is finally satisfied. Okay, so this was some troubleshooting. Now coming to our next challenge, here we are. This is the final X-ray for the case. Now the next challenge is a challenge of the resolved sinus. And this is what I was quite excited to actually talk about this. Let's have a look at this case. Now we all know that in the posterior maxilla, pneumatization of the sinus is a problem, and we can't just do simple, straightforward slam dunk implant placements. You need augmentation procedures. And we also know that the bone type is type 4 mostly, which is very soft bone. So in this case, we had about 3-4 millimeters of bone in the upper right missing molar area. And I did what is called a closed sinus lift, or an osteotome sinus lift, or the Summers technique, where you drill up to the base of the sinus and you infracture that cortical plate using an osteotome and a mallet. and do a bone graft in the space that you create, and a simultaneous implant is placed. So that's how it's done. It's not very fancy, is it? It's a rudimentary looking technique, and it has it for this design procedure. Okay. So anyway, in this instance, there were no problems really. We got the sinus elevation right. Okay, and that's the implant placed. You can see we've done some lower implants also. So that's the implant placed in the upper right posterior area with the osteotome mediated closed sinus lift, and you can see the bone graft as well. Now I found a couple of very interesting videos which show exactly.
And to achieve this better bone height. There's a bone, yes, a fractured bone. So it's clearly see how
it's done.
So now,
Is made,
since our key is bone,
inserted, and then you infracture.
If we have elevate, see
all the while ensuring that the Schneiderian membrane is not perforated. Okay, there you go. So that was closed sinus lift, and lateral window sinus augmentation also is a bigger challenge. Here is a case of this patient is a friend of mine, severely pneumatized sinus in the upper right molar area. Now with lateral window sinus augmentation, the question is, especially in our culture, should a general practitioner be doing it? Do they qualify to do it? Should the patient be referred to oral surgeons, perhaps? Okay, and so this is the basic technique, as we are all aware. Just some textbook pictures of how you can outline a lateral window in the maxillary sinus area, create some space by detaching the Schneiderian membrane from the underlying bone and filling that space up with bone graft material. Okay. Here we go. Okay, and a membrane is placed on the window. Now, sometimes this can, it's a technique-sensitive procedure. So sometimes you can have tears in the membrane, you can have large hematomas, small tears, large tears. Okay, so it's certainly a procedure which is not basic level. You need a certain level of skill for this. Okay, so these are all textbook pictures. Now, this was a case that I did. This patient is in his mid-40s, he's a diabetic, and this is a root canal which had failed, and you can see a periapical pathology, and there's bone resorption. So I thought I'd remove the tooth, do a sinus lift at the same time. So here is the root canal treated tooth, the root canal done by Dr. Sandeep Singh. I'm joking, and as you can see that the palatal socket is draining with pus. So I make my lateral window, and as you can see that I had to remove quite a lot of bone before I could reach the membrane. And as I was trying to lift the membrane, there was a tear. And I'm actually quite proud of taking this picture because, at least for a practitioner like myself who's not hugely experienced, when you tear a membrane, taking a picture is the last thing on your mind. Anyway, so when I saw the tear, I stopped elevating the membrane any further. I placed a collagen membrane, put whatever bone graft I could, closed up the window with a barrier membrane, and then suturing the flap over it. And then I go home and I start praying. Now, this patient had the premolar also, which was becoming mobile. So I lost him for a few months after this. And he came back to me, and much to my surprise, I saw bone formation on the upper right posterior area where I had done my very tricky sinus graft. So I placed an implant there, and I removed the upper right second premolar. And now this patient comes back to me once both the implants have integrated, and I'm taking an austal value of the implant that I had placed in my lateral window sinus graft, and it was 73, so that was encouraging. And then I went ahead and I restored these two implants with the two joint crowns. Okay, so this is slow to move. Okay, so these two implants were restored with two joint crowns. Okay, so I had a mental block on this for a while, actually. Just to...
Which of course brings me to rule number 3. Don't be afraid to fail. Anything.
So remembering Schwarzenegger's words, don't be afraid to fail. So I went ahead and I did a series of lateral window sinus grafts. Some of those cases I will show you here today, and how we've been managing those cases. Why is this slow? Okay, so I'm going to show you the case of my friend with the upper right missing molar. Okay, but just to keep a few basic principles in mind. What is going on? So you have to outline your windows accurately. Make sure you know where the base of the sinus is. Preferably make larger windows. The smaller the window, the greater the negative pressure, and so there's a greater chance for rupturing of that membrane. Always keep your instrument in contact with the bone when you're detaching the membrane. Detach the proximal part of the membrane first, and then proceed towards detaching the membrane from the base. Be mindful of the anatomy. Remember that the membrane thickness is only between 0.4 to 1.4 millimeters. The bone overlying the membrane can be considerably thick, and be mindful of the posterior superior alveolar artery, which can sometimes hemorrhage. So, as you can see, sometimes the bone overlying the membrane can be very thick. And smokers tend to have not thicker, but thinner membranes, where the pseudo-stratified ciliated columnar epithelium of the maxillary sinus striated membrane can undergo metaplasia and turn to simple squamous epithelium. Okay, so these are the post-operative instructions we give out to the patient. Now, coming back to our case. So I raise the flap. One of my favorite quotes by Oscar Wilde: "You are fond of me because I represent to you the sins you do not have the courage to commit." So I raise a flap and I outline my window. Okay, and when I see non-bone color, that's where I stop with making the window. That's where I stop with my depth. Okay, so gradually, slowly and steadily, using a round burr, I'm making my window. Okay, and then once I see the membrane clearly, I detach the proximal part of the membrane first, using the sinus kit for detaching the membrane. Okay, so detaching the proximal part of the membrane first, and then proceeding towards detaching the. ये पीछे चला चलने तो किसने बंद किया यार? Okay, so detaching the proximal part of the membrane, and then the base of the membrane, and then proceeding towards the bone graft. Okay, and a barrier membrane is placed, sutured up. Okay, and this is the post-op X-ray. That's the comparison between the pre-op and the post-op. Okay. So, if you get things right, it's like poetry in motion. And this is an excerpt from a book by an orthopedic surgeon. So, and one of my favorite lays, how can man die better than facing fearful odds for the ashes of his father and the temples of his gods? Okay. So now as you become more confident, this is the case which was restored, by the way. That's the case restored. Okay, and I presented this case at another contest, a poster contest in Prague in 2014, and I won third prize for it. So as you become more confident, you start to handle more and more cases. This is a 73-year-old female patient with a severely pneumatized sinus again, and so I can see that the bone is very dense. I'm getting an idea that the bone overlying the sinus membrane will be quite dense. It took me about 40 minutes to make this window. Okay, and I did, in this instance, the sinus graft and the implant placement simultaneously because I had a good buccolingual width of the residual ridge. Okay. And the graft material I used in this case was at the time a very interesting material. It's an alloplast, and the delivery system was through this cartridge in a gun. It's quite interesting. So this is the case as I finished it in the surgical stage, and that's the finished case with the crowns on the implants. Another case, now this is a bounded saddle, which can be challenging sometimes because the window that you make is small. And again, it took me more than 30 minutes to make this window because the overlying bone was quite thick and I had a bounded saddle. So it was a small window mesiodistally. Okay, and that's the graft in place again. This is again an alloplast at the time. Okay, barrier membrane to prevent soft tissue growth onto the window. And this is an immediate post-op X-ray back in 2013. And then an implant was placed 4 months later. Okay, and the implant was then restored. This is the pre-op and the post-op comparison. The implant was restored, and this is a 7 years post-op X-ray on the upper right side. Another case. Now this was again a severely pneumatized sinus, a bounded saddle. Yeah, and so that's how we used to do it. The round diamond burr. It takes a very long time to make the windows. Okay, and then I would proceed and detach the proximal part of the membrane first. Okay. So this is the case, and it's always very encouraging to see when you can see the membrane moving, which means there's no tear in the membrane, there's no perforation. Okay, so again, the same Eloplast material that I used to use at the time, and injecting the material, injecting the graft material into that, into the sinus cavity after you've detached the membrane. Very convenient, predictable. Okay, and an implant was placed simultaneously, and this is now 5 years post-op X-ray in the same patient. So predictable. Okay. So should it be a maxillofacial surgeon or me doing all these cases? And I have a response for that. Why should a prosthodontist like me be just as suited to doing these cases as anyone else? You know, Edgar Allan Poe, who was known for his horror stories, okay, and he also wrote what is considered to be one of greatest masterpieces, at least in my opinion, of romantic poetry. This is a poem called Annabel Lee. It was many a year ago in a kingdom by the sea that a maiden there lived whom you know by the name of Annabel Lee. And my favorite stanza you can see in red. And neither the angels in the heavens above nor the demons down under the sea can ever dissever my soul from the soul of the beautiful Annabel Lee. So that was just to prove a point. But you have to make sure that you get your background knowledge right. You know, I'm not going to go into details of these book chapters. This is from the ITI guidelines. But you have to make sure that you know what you are dealing with, indications, contraindications, special considerations. Yeah. Another case here, severely pneumatized sinus. Patient has perio problems as well, and this patient has another issue of negligence. It's very hard to get hold of him. So this is the window I created. Okay, I apologize. Somehow these are slow to move, my slides. So again, you can see very reassuring when you can see the membrane moving as the patient breathes in and out. Okay. Yeah. And now this patient had very good buccolingual bone width in the residual ridge. So I augmented the sinus through a lateral approach, and I placed a tapered implant at the same time with pretty good initial stability. And that's the graft in place along with the implant placement, and the membrane is placed overlaying that window all sutured up. And that's the immediate post-op picture. The graft looking nice, like a little football in there. And 4 months later, the patient comes back. I take an ISQ value of 71, which is encouraging. So I go ahead, I torque my abutment, a conventional solid abutment, and I do a snap cap impression for a cemented cross, for a cemented crown. Okay, another case. Now this patient, as you can see, has been messed around with a lot. The lower implants were not done by me, and apparently this guy is quite a big deal. He got them done from a high-end practice in the UK. Anyway, so I restored his upper posteriors. We started off with the upper left. So we did a lateral approach for the sinus augmentation, and we placed 4 implants simultaneously. Okay, and as you can see, once again, I'm detaching the proximal part of the membrane first. asking the patient to breathe in and out. Okay, and just to see if the membrane is intact. That's my sticky bone. This was an alloplast, okay, in sticky bone consistency, which was placed in the sinus here. Implants were placed simultaneously, sutured up, and that's the immediate post-op X-ray, and that's the implants restored. In the same patient on the upper right side, again, I'm doing a lateral window sinus lift. Okay, you can see the membrane moving and the patient as the patient breathes in and out. So the membrane is intact. Placing my graft material in that sinus augmentation area. And 3 implants were placed simultaneously, along with sticky bone with bone allograft in the upper right posterior maxilla. And this time his lower anteriors have finally failed, and we'll be restoring those too. Okay, so now the risks and limitations of doing these techniques with conventional armamentarium, the closed sinus lift or the osteotome sinus lift, you obviously have the risk of perforation. You have to really control the force that you apply to fracture the floor of the sinus. It's a blind procedure, nothing very gentlemanly about it. And the upper and the lateral approach, also again, it's a technique-sensitive procedure. If you're using a round burr to make the window, it can be quite time-consuming. It's not user-friendly. You need to have a certain level of expertise, especially to deal with the Schneiderian membrane, which is very delicate. And at least with a conventional approach, it's difficult to do a replaceable bony window. Now, the replaceable bony window technique for lateral window sinus grafting is something that I really wanted to start doing because I read a lot of literature about how the bony window is osteoinductive and it can give better results as far as bone regeneration is concerned. And obviously, the posterior maxilla being the weakest bone in terms of hardness, is where you would like quality bone and great GBR results. So what next? And if my friend Teddy from Dentists is watching, thank you, Teddy, for this wonderful gift. This is a sinus kit that I finally started using recently, actually about 8-9 months ago. And I'm excited like a little child. This is my nephew. The first day he learned how to stand up. You see how excited he is. Yeah. I'm excited like a little boy. Okay. And I started doing my first few cases with the lateral approach using the sinus kit. Okay, so this is a patient who we've been treating for a few years. The upper and the lower anterior implants I have done. The others I have not done. So in the upper left, she had implants placed previously which had failed. Okay, so obviously there's compromised bone volume in this area, and we decided to do a sinus graft with the lateral approach. This kit has these have these stoppers, so it becomes easier, and the stoppers range from 0.5 millimeters to 2 millimeters in depth. Okay, so now that's the 1.5 mm stopper with the lateral reamer. Okay, and now that's the 2 mm stopper with the lateral reamer, and that's the window coming up nicely. Okay, and when you start seeing non-bone color, that's where you stop. That's where the membrane is now peeking through. Okay, and now with the save instrument in the save sinus kit, you carefully detach the bony window from the underlying Schneiderian membrane. Okay, and this, by the way, was my very first case with the replaceable bony window. So that's the membrane once the bony window has been removed, and that's the bone window, which you can save in saline, and then you can proceed and start elevating the membrane, detaching it first from the proximal area, as discussed previously, and then from the base. And this is now the graft sticky bone placed in the augmented area. Okay, that's the graft being packed. That's the bony window being placed back onto the lateral window. Okay. There you go. And CGF membranes placed and closure. So this is the immediate post-op X-ray. This is a 4-month post-op X-ray showing good bone fill in the upper left posterior region. And now, after 4 months, we come back, we make a re-entry, and we see how nicely the entire area has healed. Great chunky bone growth. Okay, and I'm placing 2 implants with very high insertion torque, very reassuring. Okay, an insertion torque of 50 newtons. These are the 2 implants. That's the closure, and that's the post-op X-ray. We're yet to replace. We're yet to restore these implants. That's the post-op panoramic. So, an interesting comment here that I just want to share with you guys is about the optical radio opacity or optical radio density. If you notice that in these X-rays, in these cases, you can see how the bone graft looks more radio opaque. These are alloplasts, and again, in this X-ray, in the patient's right sinus, you can see this is less radio opaque. This is an allograft. Again, this is an alloplast. And this is a very interesting paper comparing the radio opacity of graft materials. And in some alloplasts, the addition of nano iron oxide can make them look more radio opaque. So another case, using the same kit, this patient has both maxillary first molars missing. This is the right side, where we plan to do a lateral window sinus augmentation. Okay, so flap was raised, again using the same kit. These are the lateral stoppers from 0.5 millimeters to 3 millimeter depth. Okay, so I'm using the 0.5 millimeter stopper now with the reamer. And that's all I had to use actually, because now this patient had very thin bone overlying the Schneiderian membrane. And I'm just feeling for that membrane with the elephant paw instrument. Okay, just feeling for that. and detaching the membrane just a little bit from the underlying bone, always starting with the proximal side first. Making sure that the instrument is in constant contact with the bone while we are detaching the membrane. Okay, and now trying to remove that bony window, which by the way in this patient is very thin. So you've got to be very careful to not rupture that membrane. Okay, so going very slow and very cautiously. Okay, and just pulling that out, making sure that the membrane is not damaged while you're doing that. And as you can see, the bony window in this case is very thin. Okay, that's the bony window. That's the membrane that you can see now clearly. So you proceed towards elevation of that Schneiderian membrane. Okay, packing the bone. And now this patient has, as you can see, there's a buccal defect. So I want to put a contour graft as well. So once I've augmented the sinus, I will replace the bony window, and then after making a couple of bleeding points, I also placed a layer of sticky bone in this case. Okay, so that's the sticky bone. All right, CGF membrane and closure. So this is the post-op X-ray following the lateral window sinus graft. Now on the left side, we used a crestal approach with a simultaneous implant placement. Okay, so again using the same kit, we have crestal stoppers from 3 mm to a 10 mm depth. So these are the reamers that you have in different diameters, and if you can appreciate that the reamers have a blunt, non-cutting tip. Okay, so on the upper left side, we have about 4 or 5 millimeters of bone height before we hit the sinus floor. So again, we raise a flap to replace that upper left missing premolar. You start off with the Lindemann drill. Okay, the reamer with the 3 mm depth stopper. Moving on to the 4 mm depth stopper. And now I know that I'm nearly at the base of the sinus. And you can sometimes feel the sinus floor infracturing. And at this point you can use the aqua tip. Okay, and this is how the aqua tip works. I got a very interesting educational video from YouTube. Okay, so the aqua tip will help in detaching the membrane once you're in the floor. Yeah. Once you're in the sinus and you've elevated the floor of the membrane, that is. Okay, so moving on to a 5 mm stopper. Okay, very carefully now lifting up the floor of that sinus. And making sure that I'm palpating the sinus floor that I've infractured in using the depth gauge. And the depth gauge, of course, has readings, so you know how deep you are. Okay, so now once I've made sure, I can feel the cortical plate of the sinus floor. I'm moving on to a 7 millimeter depth stopper. Okay, and then an 8 millimeter depth stopper. Again, feeling for that sinus floor with the depth gauge. And a 9 millimeter depth stopper. I haven't changed the diameter of the reamer. I don't need to, because I plan to place a 3.7 mm platform implant. Okay, so now once again verifying the depth, feeling for that sinus floor. Okay, that's the 9 mm stopper drill, 9 mm crestal stopper. And after this, I will not push my luck anymore. Just pack some bone. Okay. And just ensuring how deep I am. Okay. And once I have enough bone in there, I place my implant with good initial stability. Okay. That's the finished case. Closure. Okay, so in this patient, for the missing upper right first molar, we did a lateral window augmentation, and the plan is to come back and do an implant later. And for the missing upper left tooth, which was actually a missing molar tooth, but we have very little space there, so the tooth that we're going to replace will be like premolar shaped restoration eventually. So again, this patient, he already had an implant in the upper left second premolar. We placed another implant in the upper left first molar using the same kit for a crestal sinus lift. That's the finished case. Another case, upper left missing upper left missing second premolar. Okay. That's the sequence. The implant was placed with good initial stability. And that's the post-op X-ray. So, this probably is the last case for my lecture today, and presented this case as part of a poster contest recently in Madrid in November. It's an interesting case. So this patient came to me a couple of years ago, and he had bilateral swellings. He was in a lot of pain, and as you can see that both the maxillary molars, the right and the left maxillary molars were infected. And I took a detailed history of the patient. I could tell that he had been neglecting his health overall. So a holistic approach is what I would like to emphasize here. Now, this is the patient. He's a 45-year-old male. He's a non-smoker. He claims he's a non-diabetic. Okay, he's got swellings on both sides of the jaw. So we prescribe him baseline blood tests, which include INR and HbA1c. And the test revealed that his HbA1c was 10. So not only does he discover with us that he's a diabetic, he's got uncontrolled diabetes. So just to address the swellings and the pain, we gave him amoxil and metronidazole. We did a thorough scaling and root planing, and he was referred to a specialist physician. Okay. Now, this is very interesting. This patient, if you can make out, his HbA1c is 10 when he comes to us on the 3rd of February in 2017. Okay. And on and we're finally able to bring the HbA1c down to 5.7, from 10 to 5.7. So this guy's life is already changing, okay? And now gelling together all the skills that we've acquired in my experience, okay? So the upper, and I'm going to explain in detail the upper right side and how that was restored. So the upper right first and second molar were extracted. I let the 8 be just in case we would have to give him a temporary denture that would serve as an abutment. So these teeth were cleaned up and they were placed in the dentin grinder by Comita Bio. Okay, the particulate graft was then strained and sieved, and then they were processed in the vacuosonic again by another company, which is a very interesting technique that demineralizes and conditions the autologous tooth particles and conditions it so that it can be used as a viable graft material. And at the same time, we're using the metafuge for concentrated growth factors and the autologous fibrin glue. Okay. Now, once the autologous tooth particles have been conditioned and demineralized, the autologous fibrin glue is mixed with that particulate and turned into sticky bone. And in this case, this is now autologous tooth sticky bone. Okay, it's natural. It's from the patient's own body, so it's autologous. So 2 implants were placed in the saddle area, which teeth are already missing. These are the 4 and the 5, both premolars. And for the 6 and the 7, both the first and second molar, I did a lateral window sinus augmentation. And the graft material I used for the sinus augmentation was completely autologous. This was autologous tooth bone conditioned into sticky bone using growth factors from the patient's own blood. Okay, the sockets for the extraction sockets were also grafted. So this is the bone graft, and a collagen membrane as well as CGF membranes were used, and that's the closure. Okay, so 4 months post-op, as you can see, we've done implants on the upper left side as well. On the upper right side, you can see that I placed 2 implants in the premolars, and this is the result of the augmented sinus. Very encouraging. So I make a re-entry 4 months later. Okay. And I'm placing my implants for the first and the second molar. Okay, and with very good initial stability. Yeah. And I'm also taking an Austell ISQ value at the time of placement, which is 62, that's also very encouraging. Okay, and 69. Okay, so here's my two implants placed in autologously augmented maxillary sinus. Okay, and that's the closure. These are the two implants placed in the augmented sinus. And now 4 months later, the patient comes back, and this time now I plan to make CAD-CAM abutments again. So another technique that I'm using is intraoral scanning, digital impressions, and customized CAD-CAM abutments. So these are the CAD-CAM abutments, which are torqued and the crowns are cemented. And this is now a 2-year post-op OPG and a 2-year post-op radiograph showing stable bone levels. And this is a periapical showing bone levels around the implants. So these are the techniques we actually put together in one case. We did a lateral window sinus lift. We used autologous tooth bone, which was conditioned into sticky bone using another technique which allows us to harvest concentrated growth factors and autologous fibrin glue. We also used resonance frequency analysis with an Ostel device. We restored the implants with CAD-CAM abutments and digital impressions using an intraoral scanner. And these are the references for this case. This was presented at a World Symposium in Madrid in November. It fetched me a 3rd prize. So in the end, I'd like to tell the audience about the Royal College of Surgeons in Edinburgh, which I consider to be perhaps one of the finest institutions, especially for assessment. And ever since I've been associated with the college, I believe I've improved a lot as a clinician, as a practitioner, as an academician. I would encourage those of you who are watching, especially in my part of the world, to consider sitting for the Diploma in Implant Dentistry exam in Edinburgh. It is a fantastic experience, and once you pass, it's solid validation, solid credentials for your skill level. They do preparatory courses as well. They used to do the exam and courses only in the UK until a few years ago, and then they started doing it in Dubai as well. And hopefully, once the COVID nightmare is behind us, these courses and exams can resume. So I'd like to share, I don't know how good a teacher I am, as far as the audience thinks, but I'm not a bad teacher. So this is my nephew. My nephew, he calls me Daddy Irfan, okay? And this is, I've been a good teacher for him too. Acha. What do you say to a pretty girl?
Hello, hi, cutie pie.
What do you say to Daddy Irfan?
Hello, hi, cutie pie.
So I've been a good teacher to my nephew as well. And this is my team that I work with 6 days a week. I'm a very hard taskmaster, but we have a fantastic team. This is a picture from a couple of months ago. Good times now that we remember and look back, the pre-COVID times, as I turned 41 in February. And we have a lot of fun working together. We've done some wonderful work for many patients who are very happy with us. And I'm proud to have a team which is as efficient and passionate about what we do. I'm open for questions. I'm open to be reached out should anyone plan to contact me. Now, Sandeep, are you still there? Have you gone to sleep? Where are you?
Thank you so much for a wonderful presentation.
Are you here? Hi.
I think,
Yes, I
yeah,
can.
can you hear me?
Yeah. Listen, I gotta say, so
Yeah,
because I couldn't see myself, I all throughout I wasn't sure if you could see me.
yeah, it was a wonderful presentation, and I think you took all the topics from the implantology, right from simple placement to um, GBR to complications to sinus augmentation, and I believe that you love the gadgets, and I'm really happy to see that you are doing a lot of autologous factors into your practice, day-to-day practice, especially taking in the autotooth graft material and both the machines, the one from Korea, which was introduced by
Yeah.
Professor Dong Seok Son, the what's the name,
Yeah,
Sonic,
Pakistani.
uh, yeah, Vacuum Sonic, and definitely it takes a lot of time, but the quality of bone material which is produced is wonderful with that. I was thinking of buying it, but cost is pretty high, and in India is a price sensitive country, so I'm using the Cometa Bio, and I'm getting pretty good results. Did you ever thought of getting into the histomorphological studies of your grafting areas? Um, because I have started
Maybe
doing it, and
I
I
published too. It
valid,
was very
va-
too.
va-
So I'm yes, yeah.
yeah, because that helps in validating our cases that whatever we have achieved, it is perfect. And which biomaterial, the augmentation material which you prefer, or the availability in Pakistan?
So we tend to use allografts a lot. We use xenografts.
Hmm.
We use alloplasts also, but then, as you already know, alloplasts have that question mark as far as the organic potential is concerned.
Yeah,
And BioOS has been very popular in the market for many years. There's a lot of very high quality Korean products. I used Minros by BioHorizons for a long time. There is a Canadian brand called, I don't know if we should be endorsing or mentioning brands here, but uh,
no, no, it is not
so
the
I use a
endorsement,
brand
but
called
it is just for
that's a
the
Canadian brand, that's an
viewers,
allograft.
you know.
So, preferably, I use allograft simply because it tends to be predictable. And I've been moving away from alloplasts lately. And I showed some cases with Nova Bone, which worked very well for me. Nova Bone was, because it's really opaque also, it shows you where your graft has been placed. So you can
Yeah.
actually visualize your graft immediately. So that worked very well in my hands. And I think it's the technique, it's case selection, you know.
Yeah, that is true. But as in India, which I have experienced, that we have to be very careful about the religious belief or beliefs of the patient. So we have to be very careful, especially when we are working in the Asian countries. And like in India, I cannot place xenograft of porcine origin into a
Yeah.
Muslim, bovine graft, holy cow, into a Hindu, and if we talk about Jainism, I just can't place anything else other than alloplast. So that is the biggest thing, and um, alloplast is there, and allografts are good, but definitely when we are talking about the scaffold, we have to have a long resorption period time. So to maintain the bone and to get a good quality bone, which is like a lamellar pattern, I believe we need to have a composite uh, grafting material into that.
Okay.
So
I lost you in between for a couple of minutes. You're back now.
yeah, I was off.
Yeah, but now
I believe if you can hear me, we have another speaker on waiting, and we have to uh, bring her in. So thank you so much for your wonderful presentation, and we have a long association. So I'm really privileged and proud to present you. And I made it a point to everybody that if Irfan is going to be there, I'll be the host.
it means a lot. It means, and I just want to say one thing here. I have wonderful friends in India,
Yeah,
and we made some wonderful memories together.
yeah,
And we need to spend more time in more wonderful things and have a lot of fun.
yeah. Well, but one more thing, you missed my photographs. So
That's fun. Yeah. But see,
you
I think the thing is, you take away my thunder, man. I don't look standing next to you, so
and
it's
let me tell my viewers that he's a very versatile personality, and he's into a lot of fitness, as you can see with his physique. Uh, so he's a health freak also. And thank you, Irfan. It was wonderful having you here with us and on the Global Summit platform. And today, the responsibility was given to me by Kianor to be alone here. So thank you so much, Allah Hafiz.
thank
Um, Take care in this COVID time, and I think everything will be fine in your country, in your place. And my best wishes to all the dental surgeons over there who are practicing in these difficult days. Thank you so much. Bye bye.